Presentation of the proposed revision of H.R. 6983, the Paul Wellstone and Pete Domenici Mental Health Parity and Addiction Equity Act of 2008. An act to amend Section 712 of the Employee Retirement Income Security Act of 1974, Sections 2705 of the Public Health Service Act, and Section 9812 of the Internal Revenue Code of 1986, to require equity in the provision of mental health and substance-related disorder benefits under group health plans and for other purposes. The Paul Wellstone and Pete Domenici Mental Health Parity and Addiction Equity Act of 2008 was introduced to the House of Representatives on September 22, 2008 by Representative Patrick Kennedy. After referrals to House Energy and Commerce, Education and Labor, and Ways and Means committees, it was voted on and passed the following day. However, it was not effective until January of 2010. Mental illness is like fighting a war, where the enemy's strategy is to convince you that the war isn't actually happening. H.R. 6983 made amendments to 3 other pieces of legislation. The first is the ERISA of 1974, which is the protection of employee benefit rights. Second, it amends the Internal Revenue Code of 1986, specifically Section 9812, which addresses parity in mental health and substance abuse benefits. The Internal Revenue Code detailed, among other items, benefit limit requirements, financial and treatment limitations, as well as availability of plan information. The third amended bill is the Public Health Service Act, Section 2705, which also details parity in mental health and substance use disorder benefits regarding limitations and treatments. President John F. Kennedy in 1963 was quoted as saying, "This situation has been tolerated for far too long. It has troubled our national conscience, but only as a problem unpleasant to mention, easy to postpone, and despairing of solution." While laws have since been passed and approaches to mental health have improved, the statement from President Kennedy remains true to this day. Historically, individuals afflicted by mental illness were tortured, locked in basements to be forgotten, or institutionalized where experiments were performed on the most vulnerable of community members. Today, abuse takes the form of disparity and denial of much-needed interventions, medications, and treatments. Mariam Bendat writes that irrational and disproven fears have driven insurance providers, employers, and managed healthcare groups to discriminate against mental health coverage. John McConnell defined the need for legislature addressing parity as a necessity to reduce the stigma associated with behavioral health care and improving the financial protection of services for which there are high levels of unmet needs. Insurance companies have a routine practice of denying benefits for mental health clients, as well as those suffering from substance abuse. It is time for the intent of H.R. 6983 to reach its full potential. It is going on 10 years since the bill was introduced to the House of Representatives, and there remains significant disparity among benefits for those affected by mental health. With no defined accountability or repercussions, insurance providers continue to skirt their legal responsibility and to provide equal terms for behavioral, mental, and substance abuse benefits. Benjamin Heller points out that loopholes exist in the Mental Health Parity and Addiction Act that allows employers and insurance providers to discriminate against consumers in mental illness. H.R. 6983 demanded that mental health disorders be given the same benefits as someone with medical disorders. Treatment for bipolar disorder should be given the same consideration as cancer or heart failure. There has to be a checks and balance system to address the inefficient review process and the lack of accountability. There are bills being considered to help with this issue, but the real solution lies in amending the Mental Health Parity and Addiction Act of 2008. Enforcement of penalties and consumer education projects are two initiatives to start the revision process. It has been determined through an APA survey in 2016 that only 4% of Americans knew about H.R. 6983 and how it applied to them. Mental illness and substance abuse are difficult topics that carry negative stigmas. Those affected by these disorders, whether directly or indirectly, find it hard to start the conversations with healthcare providers that could lead to treatment. This is not a patient population that immediately seeks help when symptoms first occur. Changing healthcare provider perceptions as well as those of the community is important for the success parity laws like H.R. 6983. There has to be open communication in safe settings for the social impact to be positive and long-term. The economic impact of parity, called for by H.R. 6983, is highly debated among providers and advocates for the bill. It is argued that the increase in provided service will cause financial burden to insurance companies. However, that is not the case. Benjamin Heller points out that the mandate of health care coverage parity would raise premiums less than 1 whole percentage point. What is more important to the economical debate is the impact that untreated mental illness has on the individual, their families, and the community as a whole. With lower income populations affected at higher rates, these individuals become dependent on welfare and other government resources to survive. They are forced out of their jobs because their disease process prevents them from performing. They lose their health care benefits, which were not covering their mental health efficiently to begin with. Not demanding adherence from employers and insurance providers will continue to put greater demand on the government resources. Political elements of H.R. 6983 are found in the amendments to previous legislature. Originally, this bill did not meet a great amount of opposition. It passed the House vote on the first roll call with 376 yeas and 47 noes. There were 7 co-sponsors, including 6 Democrats and 1 Republican. However, the issue is ongoing as we continue to fight for true parity. The need for revision is one not only of medical necessity, but of ethical duty. It is past time to address the issue of disparity among some of the most vulnerable in our communities and country. Galatians 6:2, Paul writes, "Bear one another's burdens, and thereby fulfill the law of Christ." We are called to look out for each other. It is truly our calling to advocate and seek justice for those who are unable to do so on their own. Proponents to the bill include organizations like the Substance Abuse and Mental Health Service Association and the National Alliance on Mental Illness. These entities, as well as other professional organizations, continue to support H.R. 6983 as a stepping stone to true parity. However, it is understood that this is only a stepping stone, and the effort continues to obtain equal benefits. Opponents who argue against parity for mental illness and substance abuse benefits are insurance companies. Their argument is that there will be an exponential increase in cost related to their expanded physical liability, which has already been disproven by more than one study and evaluation. Advocacy for those who cannot advocate for themselves is a role that each nurse embodies at one time or another in his or her career. It is a role that nurses take seriously. In the mental health population, there is a great number of people who are unable or who are afraid to speak out for themselves. They are not prioritized among the medical patient population. Stigmas and uneducated assumptions about individuals suffering from mental illness and substance abuse leads people to avoid these individuals, which only further isolates them while widening the barrier to treatment. As advocates, nurses in the community and in the acute care setting have an opportunity to reach out, build relationships, and encourage continuity of care. Continuity of care is vital to successful outcomes in any demographic. However, with psychiatric diagnoses, continuity of care is vital to ongoing stability. Relapses are difficult to overcome and put the patient at risk for self-harm, legal trouble, or even suicide. Through community health centers and integrated care with physicians and nurses working together to build strong patient care team relationships, there is hope for long-term improvement in quality of life and lifestyles. H.R. 6983 has yet to be as effective as it has the potential to be for the identified population. Insurance companies were mandated to follow the guidelines skillfully detailed within the bill. However, lack of follow-through, lack of checks and balances, and a massive lack of accountability on the parts of lawmakers, physicians, and insurance providers has led to the ongoing maltreatment of mental health consumers, abuse of authority by insurance companies, and the ongoing disparity for those the bill was meant to protect. The time is now to stand up to organized health care, demand transparency and adherence to already passed legislation. There are new bills in the works to address the ineffectiveness of H.R. 6983. However, revision is needed to close loopholes for private insurance providers and further detail the protection for mental health consumers and those suffering substance addiction.